Chronic nonspecific low back pain affects nearly 23% of the adult population worldwide. For nearly a quarter of adults, severe pain persists in the lower back for months or years, completely divorced from any clear anatomical cause or specific injury. Patients typically turn to pharmacological interventions first. Prolonged reliance on nonsteroidal anti-inflammatory drugs and opioids introduces a high risk of systemic side effects, chemical dependency, and diminishing returns as the body builds tolerance. Physical rehabilitation modalities offer a safer alternative to long-term medication. In clinical settings, the standard of care often involves deep tissue interventions, which usually comes down to a choice between two tools: ultrasound therapy and laser therapy. In a 2018 clinical trial, researchers directly compared these two modalities. After 8 weeks of treatment, the group receiving laser therapy showed a statistically significant improvement over the ultrasound group in reducing both pain and overall physical disability. Ultrasound uses heavy, high-frequency sound waves to physically vibrate tissue and generate deep heat. Light has no physical mass. We have to examine exactly why light outperforms deep mechanical heat in treating chronic back pain. Low-level laser therapy, or LLLT, has evolved in clinical literature to a more accurate descriptive term: photobiomodulation, or PBM. PBM faces heavy skepticism in the broader medical community because the patient often feels nothing during the procedure. Critics frequently assume any reported pain relief is either the result of superficial skin warming or a strict placebo effect. To prove actual physiological efficacy, researchers rely on double-blinded, sham-controlled trials. Patients are treated with devices that look and sound identical to the active lasers, but emit no actual irradiation. Neither the patient nor the operator knows if the machine is turned on. When patients respond better to an active laser than a sham device, the relief cannot be attributed to the placebo effect. The explanation lies entirely in the physics of how light interacts with human tissue. Ultrasound generates its therapeutic effect violently shaking cellular structures to create heat. Photobiomodulation operates on an entirely different physical principle. The intervention does not rely on thermal effects, it does not burn the skin, and it does not significantly heat the targeted internal tissue. The process is driven by a photochemical reaction. Similar to how a plant uses photosynthesis to convert sunlight into cellular energy, human cells contain photoreceptors capable of absorbing specific light particles and translating them directly into biological changes. To reach these internal photoreceptors, clinicians use specific wavelengths, specifically red and near-infrared light. These wavelengths pass through the epidermis and outer layers of fat without being absorbed as heat. This allows the photons to travel deep into the body, reaching the dense paraspinal muscles and the peripheral nerve roots of the lumbar spine. The laser acts as a chemical catalyst, not a heating pad. Once the photons reach the target tissue, they trigger 3 highly specific analgesic effects. First, the absorption of the photons induces a direct peripheral neural blockade. The light exposure alters the axonal transport within the nerve fiber. This physically interrupts the propagation of the pain signal, stopping it from traveling up the peripheral nerve toward the brain. Second, the localized irradiation suppresses central synaptic activity. This prevents the spinal cord from misfiring and amplifying incoming pain signals, a common problem in patients with chronic back conditions. Third, the light triggers the direct modulation of neurotransmitters in the surrounding tissue, creating an immediate, localized anti-inflammatory effect. This chemical cascade physically forces muscle spasms to release and rapidly clears interstitial edema, the cellular swelling that places mechanical pressure on the lower spine. As a direct biochemical inhibitor, PBM dismantles the physical mechanics of the pain cycle at the cellular level. The biological theory is sound, but it requires clinical proof to verify if the photochemical reaction translates to actual pain relief. In 2016, researcher Gregory Glazov published a comprehensive meta-analysis to test exactly that. The review maintained strict inclusion criteria, analyzing 15 randomized controlled trials encompassing over 1,000 adult patients suffering from chronic nonspecific low back pain. Crucially, the analysis only included trials that used blinded sham laser controls. This isolated the exact biochemical effects of the light from any potential placebo response. The researchers focused entirely on immediate and short-term pain reduction following the final treatment session. This forest plot visualizes the included studies. The combined data diamond sits to the left, indicating a clinically important reduction in pain. Look closely at the heterogeneity statistic. An I-squared value of 70% means massive inconsistency. Some studies succeeded, while others failed completely. The data proves the light is effective overall, but the extreme variance means that the therapy is highly sensitive to how it is applied. We have to break the data down by specific variables to find out why certain trials failed. The researchers filtered the results by the physical energy output of the lasers, isolating the exact dosage administered to the patients. This chart breaks trials into low and high-dose interventions. For treatments using less than 3 joules per point, the subtotal diamond rests squarely on the 0 line, showing no significant difference. When dosage exceeds 3 joules, the diamond moves far left, heavily favoring active laser. A second variable emerges when looking at the patients themselves, the duration of their baseline pain. The analysis showed that PBM is highly effective for patients whose pain has lasted less than 30 months. For patients suffering longer than that, efficacy drops significantly due to established central sensitization in the nervous system, which becomes highly resistant to localized intervention. The dosage threshold is a biological requirement. Without sufficient joules, photons simply cannot penetrate deeply enough into the lumbar tissues to reach the nerve roots and trigger the necessary photochemical reaction. The final variable explains the remaining inconsistencies in the data. It comes down to how the clinician physically applies the light to the patient's skin. Several trials utilized laser acupuncture, a method where the practitioner focuses the laser irradiation strictly onto highly specific traditional acupuncture points or isolated trigger points. The alternative is non-acupuncture therapy. This involves broad field irradiation, where the clinician manually scans the laser over large general anatomical areas of the lower back. This forest plot compares categorical outcomes, patient global improvement, between these two application methods. Laser acupuncture results are non-significant, sitting on the 0 line. Broad field therapy, however, generated a highly significant success rate, with patients over twice as likely to report improvement. The failure of laser acupuncture comes down to physics. When light strikes the skin's surface, it scatters outward through the underlying tissue. Broad field application purposefully utilizes this scattering effect, ensuring that adequate energy reaches the deep, diffuse pain generators of the lower back. Trying to target a single, precise point often means missing the required volume of tissue entirely. To effectively treat the complex structures of the lumbar spine, practitioners must apply broad anatomical field irradiation rather than isolated point targeting. The clinical data identifies a specific evidence-based set of requirements for treating chronic nonspecific low back pain with light therapy. First, the energy output is non-negotiable. The dose must exceed 3 joules per point to achieve depth penetration. Second, the application method matters. Clinicians must use broad field tissue irradiation, completely avoiding isolated laser acupuncture points. Finally, patient selection dictates the outcome. Treatment is highly effective for chronicity under 30 months, optimizing the chances of full symptom reversal. Photobiomodulation bypasses the risks of pharmaceuticals and the mechanical heat of ultrasound to halt pain at the cellular level. It is a precise biochemical tool, and it yields consistent results, provided it is applied with the correct physical